system disorders, okay, those are going to be the ones that are typically your facial, okay, the GBS, okay, has that ascending paralysis, okay, starts in the periphery, therefore a peripheral nerve disorder, okay, numbness and tingling in hands, my legs don't work, and then rapidly I become paralyzed. Okay, that can include my diaphragm. So respiratory becomes an issue. Okay? When we look at our central nervous system disorder, we're looking at disorders that affect our brain and our spinal cord. Okay? And our brain controls absolutely everything, doesn't it? Okay? So when we look at kind of sub-disorders of our brain and spinal cord, okay, we have traumatic brain injury. Okay, then we have our whole gamut of spinal cord disorders and spinal dysfunction. Okay, those include spinal shock, neurogenic shock, and autonomic dysreflexia. Those are three things that we can see in our patients that have spinal cord disorders. Okay, so I am a football player and I take a hard hit. Okay, I immediately get looked at for two types of shock. Okay, spinal shock, okay, that is the immediate, temporary loss of function. Okay, it usually only lasts about 24 hours. Sometimes it can go into 7 to 10 days or a couple of weeks. Okay, but that's because there's been swelling, there's been injury to an area of the spinal cord where it's being compressed. Okay, but it is temporary. Okay, that's why when we have somebody that comes into the ED and they have a spinal cord injury, we don't ever make the promise that they're going to walk again. Never, ever, ever. Why?
Because we don't know yet.
We don't know if they have spinal shock, okay, or if they're going to be at risk of autonomic dysreflexia because they have had a complete spinal cord injury. Okay, it's way too early. Okay, and I have taken care of patients who years after their spinal cord injury still say, I'm going to walk, because somebody in the ER or in the ambulance told them that they were going to walk again. Okay, so never make that false promise. Okay, so temporary is spinal shock. Okay, but then we have to worry about autonomic dysreflexia because now I've had this spinal cord injury. And these are usually your what we call higher level spinal cord injuries, and those are your T6 and above. Okay? So, with autonomic dysreflexia, remember that's a life-threatening crisis situation. They're going to have extremely high blood pressure and flu-like symptoms. Runny nose, I don't feel good, headache. But one of the telltale signs are goosebumps below the level of their injury. They're going to be flushed above the level of the injury, and their skin will be pale below their lesion. Okay, so flushed above, goosebumps and pale below. Right? So typically their legs will be pale and they'll have goosebumps. Okay, but their chest, like if they've had, in thoracic, you can almost see a line. They'll be red up here and pale down below. In people of color, it's a little harder to tell, but you will still see a change in their skin color. Okay? The neurogenic shock, okay, is something that we have to watch for the first 24 hours. Okay? And it's neurogenic because it affects the nerves. The nerves will have a decrease in blood pressure and a decrease in heart rate. So we may be giving these patients a lot of fluid. Okay? Because everything vasodilates and they are at risk of severe hypotension and bradycardia. Okay? Does that make sense?
With autonomic dysreflexia, isn't that the one where they'll sweat like right where they're injured, right above their injury?
Yeah. Okay, and what's the primary source of the cause of it?
Bowel and bladder.
Bowel and bladder. Okay, now I have seen rare things where clothing, restrictive clothing. We had a patient in rehab one time that had, those elastic waisted sweatpants that had the string tie, and then they had the elastic cuffs, and it was the elastic that was causing the sensation. So it can be almost anything constricted. Okay, so, but bowel and bladder, number one. Okay, and how do we treat it? What do we do? Release the tension. Okay, get them up. Okay, but release the tension. Okay. And then I wanted to make sure you guys understood ICP. Okay, increased intracranial pressure. Increased intracranial pressure isn't just this isolated disorder all by itself. Okay, something causes increased intracranial pressure. Okay, meningitis, encephalitis, stroke, traumatic brain injury, okay, a spinal cord injury. Any of those things can cause increased intracranial pressure. Okay, because remember, your brain consists of basically three things. Okay, the brain tissue itself. Okay, then it has blood circulating, and it has cerebral spinal fluid circulating. Okay, so if something happens and I start to bleed, and there's an increase in the blood, the brain tissue and the CSF work together to try to still fit everything into the skull. Okay, but it can only do so much. Okay, because the skull is this huge encapsulated thing to protect the brain, right? So if the fluid level changes and my brain starts to swell, my brain can only swell so much, right? And then where's it going to go? What happens? If we don't medically intervene, what happens?
Stroke or hemorrhage. I said stroke or hemorrhage.
Stroke or hemorrhage.
The pressure's just going to build up because it's not going.
Pressure goes up. You're going to get brainstem herniation. Okay, because the only place, okay, unless we surgically go in and remove a portion of the skull so that there's pressure relief, we're going to have brainstem herniation. Okay, because that's the only place, that's the only foramen, really, because the brain's not going to come out our ears or our eyes. Okay, but that's where we get brainstem herniations. Okay, we get bleeding, we get swelling, so fluid build up so much that the only place it can come out is the brainstem. And then what happens? We die.
Is that why they do burr holes?
Okay, so burr holes will relieve. When I said cut the skull open, that's how we relieve. Okay, and how do we measure ICP? Okay, but is there a device? How do we know? Anybody? Okay, there's a catheter. Okay, so they burr a hole, they'll take a drill, they'll drill a hole into the person's skull, okay, and they insert a ventricular catheter. Okay, now they can place it in different places of the brain and then it's called something different, but typically it's a ventricular catheter, okay, that is hooked up to a monitor that then measures the pressure. Okay, now, what do you think is important when we are taking care of someone that has a catheter in their brain? What would be important to keep in mind? What?
Infection.
Infection, yes. Okay, so we have to make sure that we're not coughing and sneezing and, we have to use clean aseptic techniques when we are dealing with someone that has that type of injury. Okay? Because if we are coughing and sneezing and are dirty, what's going to happen? they're going to get infection. Okay, brain abscess. Okay, we could give them meningitis. We could give them encephalitis. Okay, so there's a physical catheter. They drill a hole in their head, and a physical catheter is put in. Okay, but I think a lot of times the students think, oh, ICP is like its own disorder. No, it's not. Okay, I can have a stroke, and I'm at risk of increased intracranial pressure. Okay, I could have a head injury, and I'm at risk of increased intracranial pressure. I could have a spinal cord injury, increased intracranial pressure. Okay, does that make sense? Okay, and then with increased intracranial pressure, you always have to be alert to those signs and symptoms. Okay, I know that Sally talked about the Cushing's triad. Okay, your blood pressure, heart rate, the widening pulse pressure, but there's lots of other things. Okay, irregular pupils. Okay, projectile vomiting. Okay, and guys, I mean like to the wall projectile vomiting. Okay, blurred vision, irregular pupils, confusion. Okay, I think your book, Maza, can I borrow your book? I think your book has a nice table that talks about all the signs and symptoms of ICP. No. 907. Look at you. Yes. Okay. And the alteration in their level of consciousness is usually the first sign. Okay, so you're taking care of somebody, they were easy to arouse or already awake when you walk in the room, and then 20 minutes later you go in and you have to sternal rub and get them to wake up. Okay, that's why we do the Glasgow Coma scale. Okay, because what does that tell us? What is it measuring?
Level of consciousness.
Yes, and we use what three things to tell us how their brain's functioning? Motor function,
Sensory perception.
eye-opening, best motor, best verbal, best eye-opening. Okay, now I will tell you, you will have to be able to assess a person's Glasgow Coma scale for probably the quiz and the test. Okay, you don't have to have the Glasgow Coma scale memorized. The little graph will be there, but you need to kind of practice. Okay, if they know who they are, but they don't know where they are, they can't follow commands, what score do they get? Okay, all right, and if they have, let's say, you tell me to squeeze both my hands, and my left arm is in a cast, and I can't squeeze, do I take points off for that? No, because that's not them not being able to follow my command because they can't follow my command. That's because their arm is in a cast and they can't. Okay, so if there's a brace or something on there. But now, if I have had a stroke and I can't hold my arm out, then I cannot follow command, and I get the points off for that. Okay. Thank you. Let's see. With all of the disorders, what was one consistent nursing assessment that you did besides your neuro? Respiratory. Why?
Because it controls the breathing. The brain controls the breathing.
Yeah. And if I have issues with my breathing, what happens? I die. Right? Okay. And when we think about all of our patients, whether that be my spinal cord injury patient, okay, my Parkinson's disease patient, my MS patient, okay, my respiratory function at some point is going to deteriorate, okay, and I'm at risk of pneumonia. So that turn, cough, deep, breathe, all of those exercises are hugely important because a lot of times, when we think about, do you guys know who Christopher Reeves was, the Superman, like in the old Superman movies? Okay, he fell off a horse. Okay, he was an avid equestrian, fell off a horse, had a high spinal cord injury, and broke his neck. He lived for years, okay, after his spinal cord injury with a ventilator. He had a portable ventilator, okay. What killed him was pneumonia, okay, and unfortunately that's something that happens with a lot of our neurological patients, whether it's spinal cord, MS, any of them, okay, they can't protect themselves from the respiratory disorder, okay? And that's what kills them, okay. Just in general, I mentioned making sure that when you're studying, okay, keep your central brain spinal cord separate from peripheral, okay. Your assessments, you do the Glasgow Coma scale, okay. But Sally should have also talked about posturing, okay. And when we see that posturing, and posturing is a component of your Glasgow Coma scale, okay, whether it's decorticate to the core, or decerebrant, where they're kind of arching their back, their chin goes back, they become very stiff. Okay, those are what I call omnious signs. Okay, when we see those patients aren't coming back. Okay, that is significant brain damage, virtually irreparable. Yes, the posturing in general. Okay. And a couple of years ago, we had lectured, it was pre-COVID because we were headed to go take a tour at Rusk. And on our way home, we had gotten there, coming home, there was an accident. And the students were some of the first on the scene and recognized, I had just lectured posturing, and recognized that the individual in the car accident was posturing. And with posturing, any stimulus can cause, it could be the light, it could be sound, it could be touch. But decorticate into the core, okay, so their wrist will come in, their chin comes down, their toes get everything kind of comes in, so I always remember it, decorticate to the core, okay, and then decerebrant, the chin will fly back, their arms flail out, and they're stiff usually, okay, and their toes point down. Okay. Once you see it, you guys will never, ever, ever forget it. Okay. What else? If there are meds mentioned in your book, make sure you know those. Okay. Like, I don't know. There should be a treatment of choice, okay, for stroke. There should be, she should have talked a little bit about seizures. Traumatic brain injury, how do we treat the swelling of the brain, those types of things. So go back, if there is a med mentioned in your book, or she mentioned a med in class, make sure you know those, okay? With all of our disorders, whether it is, I've got a spinal cord patient, and they're on medications for spasticity of their muscles, or I've got a seizure disorder. We have to encourage adherence to meds, okay? Because what happens if I don't, and it's the same with hypertension. What happens if I quit taking my meds?
your symptoms will increase again.
Yeah, your symptoms are going to improve. And, a lot of times people, they'll be diagnosed with hypertension, they'll take their meds, and then they're checking their blood pressure at home, and they say, oh, well, my blood pressure's better now. I don't need my blood pressure medicine anymore. Well, their blood pressure's better because they're taking their medications. Sometimes we see that in neurological patients. Like if I'm on seizure medicine, well, I haven't had seizures for 6 months or a year. I don't need my seizure medicine anymore. Well, they can't just stop taking their medicine because what's going to happen? They're going to have seizures again. If I have hypertension, my blood pressure's going to go up. I'm at risk of stroke. All of those things rear their heads back up, and I'm at a risk of those things coming back. And they can be worse because I haven't had my medication. So patient teaching, medication adherence, all of that is so important when we're teaching them. Okay. Any questions? Those were kind of the big things. Make sure you know your different assessments. The Glasgow Coma scale, if there are assessments for reflexes, those types of things. Like, what would you do, like, as a nurse, okay? If you're taking care of someone with, I'm in the ED, okay? And a patient comes in, they've been in a car wreck, they were ejected, but a passerby brings them in. What are you going to do? Your overall assessment, okay, we're going to kind of like stabilize them, okay, don't move anything, okay, immobilize them, and then we start airway, breathing, circulation, okay, because, do I have neurological deficits? And these things are all happening at the same time, okay? As I'm assessing their airway, I'm also looking up and down their body for any lumps, bumps, bruises, body parts that are going the wrong way, those kinds of things, okay? So you're getting to the point where when you walk in a room, okay, you should already be assessing like a rapid head to toe, like quick. You're like, oh, your eyes are open, you look at me, you talk, you don't look like you're in distress, I don't see any bleeding, there's no drainage from any orifice that I can see. We're doing pretty darn good, right? Yeah. Okay, versus you walk in, it's like, ooh, we have blood everywhere. They're not awake. Okay, so those rapid assessments. Okay, and do we have to tell a patient, I'm going to do a Glasgow Coma scale on you now? Okay, do we have to say that? No, because we can just say, hi, good morning. Can you tell me your name and date of birth? Do you know where you are? Okay, can you squeeze my fingers for me? Okay, can you push and pull? Okay, and what did I just do? I just did my Glasgow Coma scale. How long did it take me? Yeah, not long at all, did it? Okay, so when you're assessing, that's how quick those things should start coming. Okay. Any questions, guys? Did Sally talk about like pin care or anything like that? Like when we have, and it may be more with musculoskeletal, but sometimes with spinal cord injury patients, they'll have a halo. Did she talk about halos at all? Okay. I'm probably jumping ahead. What?
It was in that chapter.
It was in that chapter? Okay, well then let's talk about it. So halos, is there a picture in your book of a halo? It would be in the section with patients with spinal cord injury. When we have patients that have spinal cord injury, we really have to encourage them to perform skin assessments, or their caregivers to perform good skin assessments, because they are at huge risk of skin breakdown. Okay? They may get up, or their caregiver will get them up in the morning, put them in their chair, and they stay in that chair from 5 a.m. until 10 or 11 o'clock at night. Okay? And depending on my type of spinal cord injury, I may not be able to shift my weight a lot. So if there's a crinkle or something in my clothes, or I'm sitting on something in my wheelchair, I don't know it. And that can cause skin breakdown. A lot of the cervical fractures of spinal cord injury patients will have the halo device. And what page is that? 883. Okay? And this is a device that applies traction and immobilizes the neck all at the same time. Okay? And they're going to wear this for months after their injury until their fracture heals. Okay? The thing with it is that it is drilled into their skull. Okay? So if you look at that picture, okay, you can see those 2 silver metal screws that go into their forehead. Okay? Nursing does not ever touch that. Okay? Only the orthopedic surgeon will alter that. So when we're teaching patients, do not let anyone get a screwdriver and try to adjust your halo. If you feel there's an issue with your halo, you need to come back and see us. Okay, but you will be surprised at how many people try to take medicine into their own hands. And, it's, I've seen a doctor on TV, so now I'm going to pretend that I am one. Okay, no, don't encourage them that if there's an issue, you need to come back. Okay, just clean with soap and water. Okay, we don't use hydrogen peroxide. We don't put a whole bunch of Neosporin or any type of goop, but we want to assess those pin sites probably about once a day, once a shift, if they're still in the hospital, as part of our assessments, to make sure that they're not developing an infection. Okay? Because what happens, if I get an infection, what can happen? Meningitis. Yeah. Okay? But that ring goes around their head, okay, and then it holds their neck up, and then it rests on their shoulders. So it immobilizes and provides traction. Okay, but they could be at home. They don't have to be in the hospital. Okay? So you may, be walking around Walmart or Target someday and be like, oh, look, they must have had a high cervical fracture because they're walking around with a halo.
What do you mean by traction?
So
Traction with the screws?
Well, so on the top part, do you have your picture?
Yeah.
Okay, so here, and so the circular rod, okay, is then hooked to usually 4 rods that come off of that, okay? And there's kind of, there's like little notches sometimes in those so that it stretches the neck so that those bones can heal properly. Okay, so just like the concept, and you haven't gotten to musculoskeletal yet, but sometimes we have people in traction on their legs, okay, because the bones have fractured, and a lot of times the fractures will cross over, so we have to apply traction. We have to pull those bones back, get them set to where they are properly in place, and then the traction applies counter pressure so that they stay in place. So that's what I mean by traction. It's holding the neck up.
Traction would be extending retraction.
Yes.
Okay.
Yeah. So it's holding the neck in its normal, proper alignment so that everything stays in place to heal properly. Because if we don't, with a spinal cord injury that's high, okay, it's going to compress, and then we're going to have risk of spinal cord injury. Okay. So traction to hold it apart, to kind of keep it that way so it heals. Takes that pressure off the spinal cord. Okay, and just, I want you guys to like go home and think about what your life would be like if from now till forever you were in that sitting position. Where's your favorite box of cereal, Maza? You don't eat cereal. Okay. Well, my favorite box of cereal is on the top shelf. Okay, because I don't want anybody else to get it, right? Okay. But if I'm in a sitting position for the rest of my life, can I get my cereal? Okay. Where are the knobs on your stoves?
Mine are kind of in the middle, on the front.
Okay. You have to have a stove, Maza. Up on the top. Okay?
Yes.
Top.
Yeah.
Can you reach them in a wheelchair?
Probably not.
No. Yeah.
You might get burned
Yeah.
trying to.
Yeah. Okay. Your laundry. Your washer and dryer. Where are the knobs? Back. Yeah, mine too. And for whatever reason in our house, they're elevated on like a little 6-inch thing.
Mine
So,
too, mine are on pallets.
I'm like,
I'd never be
who-
able to reach that.
yeah. I'm like,
I
no
think
wonder
you have
people
the
lose
stairs to
socks.
get to it.
Like, there are times where I'm like, I am going to fall in here. Okay? But would I be able to do laundry? Okay, so, I mean, I say that kind of jokingly, but that's the kind of thing that I am walking, talking, everything is great in my life. Maybe not great, but, okay. And then I have a stroke. I have a spinal cord injury. And I am now not what a lot of times they call an able-bodied world. Okay, where I can reach things in my cabinet. Okay, I can wash dishes.
Are you able to even get into the house if you
Right.
have steps?
Absolutely. Okay, I mean, my husband laughs at me all the time. We bought a new stove, like mid-COVID, and I was like, oh, it has to have knobs on the front. He was like, what does it matter? I'm like, well, we're getting old. This may be the last stove we buy. And he was like, are you kidding? I'm like, no, I'm serious. Like, and when we remodeled the bathroom, I'm like, oh, we have, it has to be big. We have to be able to get a wheelchair in and all this. And even my contractor was like, why is your bathroom this big? I'm like, because we need to like be able to, like, it may take 2 or 3 people to get me in the shower. And they're all like, oh my God, you've lost it. But I mean, we don't think about those things. My brother-in-law just passed away, and that was one of the things that was so frustrating for my sister. With him, her, and any type of the wheelchair, they couldn't get it through the bathroom door because their doorways were like 32-inch doorways instead of 36 or 48. Okay, and we don't think about those things. So that just adds another stress to the caregiver role and to the patient because it's like, I'm a burden. And then a lot of times, we have these strokes, traumatic brain injuries, those types of things. And am I going to stay in the hospital the rest of my life? No. They're ready to send me to rehab and then to home. But my home is not equipped to take care of me now. So we have to build a ramp. Okay. Have you all looked at the price of lumber?
It's ridiculous.
Oh my gosh. My sister had a ramp built. It was $1,500 for like a 4-foot by like 4-foot ramp. Literally, it was like one sheet of plywood and some little 2x4s. $1,500. And that was just so that she could get her husband in the house. Okay, not to say, okay, we have to remodel a bathroom. Okay, and one of the things, a lot of times they'll take patients, they'll do like a home visit so that they can make sure that the home is safe for them. And sometimes they'll have to go to a skilled care facility because the home isn't ready. And can you imagine being 16, 18, 25-year-old's age in a nursing home until your house is ready? Isn't that a little demoralizing? Yeah. Any other questions that I can answer for you guys, or questions that you had from studying? I have to be at Project Homeless by 9, so we won't go all the way till 9. My alarm is set to go off here in just a minute to remind me that I'm supposed to be. No?
Is there anything like specific that we should really like dive into when we're studying? Like I know like all of it's important.
All of
but-
it? All of it, yeah. Stroke is hugely important. Like the nursing role, like understanding, okay, what, if I have this type of patient, what do I have to worry about? What would be my priorities? How am I going to treat that patient? Okay. We talked airway. Okay. Airway, breathing, circulation. We're going to stabilize the spine if it's a neuro and or not. I can't tell you how many times people think, like, oh, hi, I just fell, off my horse and here I am. Let's get a seat collar on you so we can preserve your spine. Just those types of things. Really understanding how you're going to treat those patients. Your assessments are hugely important. Because, like with spinal shock, okay, or neurogenic shock, I'm fine 1 minute, and then the next minute I'm not. So you have to be on that. Okay, that's why, I mentioned just briefly when I was up, alarm fatigue, and do you guys know what I mean by that? Like we have so many beeps and bells and whistles and chimes in our life that as nurses, a lot of times when we're on the unit, we start to tune those things out. And that's the absolute worst thing we can do. Because when we turn those alarms off, okay, that's that patient's lifeline for us. We have to have those on and we have to be attentive. Whether it is the O2 sat monitor, the bed alarm, we need to be in there. Okay? So those types of things. Okay, I always say understand the who, what, when, and where. Okay, so the who, what it is. What's the disorder? Who does it happen in? What kind of signs and symptoms is the patient going to see? What should I be looking for? Okay, and then what is my role? How am I going to fix it? What kind of medicines? What kind of x-rays or labs? And then, kind of how do I prepare them? What kind of teaching, education do they need to go home? So kind of the who, what, when, and where. Okay. Does that make sense? Yeah. I just wanted to make sure that you guys understood specifically, because, and I have to tell you, it never really dawned on me that students would think ICP was like its own. See, there's my. Quit talking, McCord. Got seniors waiting for you. That ICP was its own little thing. Okay. Until I started teaching. And, I had a couple of students here and there start missing it. I was like, okay, help me understand. And they're like, well, it's just this one disorder. And I was like, oh, no. ICP is just like almost your blood pressure. You're going to monitor it. Okay? And we can see it elevated in almost any of our central neurological patients. Okay, so brain, spinal cord patients. We're not typically going to see it, with Bell's palsy. With our peripheral nerve disorders, we're going to see it with those central nerve disorders. Okay, specifically stroke, traumatic brain. So, and, safety, education, skincare, safety. A lot of times they become very afraid to stay alone. And you have to remember that when patients have neurological disorders, okay, they may recover, but guys, they're never going to be the same. Never. Okay, whether it's a spinal cord, traumatic brain. With traumatic brains, a lot of times their personality completely changes. Okay, they may have ups and downs. Somebody who was, like happy, telling jokes all the time, now is real grumpy and mean. They may cry all the time, and that's really hard on caregivers. And it's hard on the patient because they're like, oh my gosh, I don't know why I'm like this. I didn't used to be like this. Okay. Anything else?
If someone's having a seizure, as a nurse, we should stay with them
Oh, absolutely.
the whole time.
Yeah. Okay. So.
And time it.
So you walk in, somebody's having a seizure, okay? First thing you do is you look at that clock, okay? You stay with them, you protect them, okay? We're not going to hold them down, okay? But if they're doing a full body seizure, you want to note, okay, what part of their body is seizing, okay? Because sometimes it'll be unilateral, it will be one side that's moving versus their whole body, okay? We want to protect all of that as much as we can, okay? Now remember, a lot of times when people are unconscious, they may be able to hear us. We don't know. But if I have a seizure, usually I'm going to be incontinent of bowel and bladder. Okay? So those are things that we want to provide dignity and respect as much as we can. A couple of years ago, we were at Richardson for, I don't know, some big complication or something. Nursing always. We're early, and we sit in the front row. That's just how we roll, okay? I don't know what happened, but nursing was late, and we had to sit in the balcony, okay? We're in the balcony, President Rome is talking, and we hear this commotion behind us. There's a student behind us seizing. Okay, well, what do? We're nurses. We roll into action, okay? Dr. Rome looks up, and he's like, oh, nursing's got it. He just keeps on. Okay, but the kiddo had stopped taking his medicine. Okay, had a seizure. I ripped off my jacket, put his head in my lap. Okay, we tried to get him on his side. Okay, but look at the time, protect their head. Anything else that may be flailing about. Okay, and then reassure them when they wake up. A seizure expends so much energy, okay, because it's like all of this crazy firing of every neuron in your brain, okay, if it's a general seizure. If it's a partial seizure, it's one little portion, okay. Note the time, what part of the body, okay, and how long that seizure is, okay, because that determines what type of seizure, because they can go right back into another one and start having those grand mal epileptic seizure patterns. Okay, but don't stick anything in their mouth. Okay, and then reassure them. Like, you're going to have to get right in their face. You're fine. You've had a seizure. I'm a nurse. I'm going to help you. You are okay. Slow, direct eye contact with them, because they'll have what's called a post-ictal phase, where it's almost like they're drunk groggy. Okay. And they're really unsafe at that point. Like, you don't want to just say, oh, you had a seizure, go on. Okay. Makes sense?
Mm-hmm.
Yeah. Note the time, stay with them, don't stick anything in their mouth. We used to try to do that. People got bit. It was awful. We broke teeth. Evidence-based practice. Don't do that anymore. Yeah. Just turn them on their side. Okay. They may drool. Be real sweaty, incontinent. Okay? Anything else, guys? Okay, did everybody get signed in? And then Miss Michelle tells me that she gives you guys candy. So, grab your candy.